So for the last speaker of the day, we just want someone that setting up the tone for the debate who will follow. So we have Shahar Almog, PhD candidate at the University of Florida, where she's based at the Behavioral Psychopharmacology Lab led by Dr. Meredith Berry. And she's going to talk to us about the misuse potential of off-label ketamine among real-world patients in the United States.
Yes.
Thank you.
Thank you so much for having me here. It's been a really extraordinary day seeing you and hearing the science in person. I am Shahar. I'm a PhD candidate at the University of Florida working with Dr. Meredith Berry in the Human Behavioral Pharmacology and Decision-Making Lab. All right. Where do I pass this? All right. No conflict of interest to declare. And I want to thank the Source Research Foundation for supporting this research. I'm not a psychiatrist in training. I'm a substance use researcher in training, one that looks at substance use with a behavioral lens. And I want to start with a very basic assumption in our field, which I'm sure you all know, and it's that every mind-altering substance has a potential to be misused by some people. Different people use different substances for different reasons. Some people just really like drugs. But some people use substances to cope with poor mental health. Substance use disorders are often comorbid with depression, anxiety, and other psychiatric conditions. Other people self-prescribe substances to cope with underlying pain condition. And chronic pain is also often comorbid with depression and poor mental health in general. So both of these vulnerable populations are being treated with ketamine. And while ketamine is an amazing medication for many of them, even life-saving, under another head, ketamine is also an addictive club drug. It is a controlled substance in the United States, classified as Schedule III. Ketamine is getting a lot of traction lately, and it is likely to increase the recreational use. People are more open to experiment with it. They hear it's therapeutic. Additionally, it's about 29% of recreational users already meet, it's estimated that they're already meeting ketamine use disorder criteria, use that might be harmful. So the misuse potential of ketamine among this new population of patients is concerning, especially that ketamine is a periodical treatment, potentially lifelong. Ketamine is not FDA approved in the United States for depression, but you can get ketamine off-label in hundreds and hundreds of private clinics across the US, administering ketamine and infusions, injections. To lengthen the interval between the treatments, some patients are prescribed with at-home low-dose lozenges. But you can also get high-dose lozenges online. Instead of the infusions, you meet a counselor online, and the ketamine lozenges are being sent to you. So we actually didn't recruit this. We didn't look at this population, but we recruited through the clinic patients that are being treated in the clinics. But I just wanted to mention, because some of them wrote in the survey that they started at the clinic, but they switched into this more affordable option. There's also ketamine-assisted therapy. Again, this is outside of the scope of our survey, our study. What's in the literature about the misuse potential? Not a lot. Some studies followed up with participants from clinical trials. Post-participation, they did not find craving or intent to use or use outside the clinical trial. However, we need to remember that usually the clinical trials are only 1 to 6 treatments, and the doses are usually lower than what's in the real-world practice. These are usually just the initial doses. So it's still a gap in the literature, and we need more data on that, and this is where we come in. So we administered an online anonymous survey, recruited real-world ketamine patients, some really long-term, asked them about benefits and risks of the treatment. We recruited through The clinics, some providers sent out our email with the invitation, with the link, or posted it on their social media, or sent it in their newsletter. We're still collecting data, so if there are any providers here that would love to come and help us, please come say hi later. I'm going to focus now on the misuse potential parameters that we included, and this is starting with the FDA guidance. The first one is liking, from -50 to +50, dislike to like. We had 2 items for craving intensity and craving frequency. We asked them about the likelihood of them using ketamine in recreational context if they were offered ketamine in a party, for example. We asked about 3 products. We asked about 50 milligram lozenge, 250 milligram lozenge, and unknown dose powder. We included 7 misuse-related behaviors based on modified from the DSM-5, items like ketamine is taken at higher frequency or higher doses than what the provider originally recommended, or sometimes ketamine is taken for fun, or ketamine is being purchased from different providers, items like this. And lastly, we included behavioral economics demand for ketamine using a novel hypothetical ketamine purchase task. Behavioral economics is a framework that is highly used in substance use research because it allows us to quantify decision-making and choice beyond the liking. For example, I love cheesecakes. Does that mean that I'm going to buy and eat a cheesecake every day? No. Same with substances. So the demand for ketamine is quantifying the motivation of the individual to purchase and consume ketamine across escalating prices. The novel task is based on alcohol purchase tasks, cannabis, opioids, cigarettes. These are highly validated tasks that their outcomes are associated with real-world substance use outcomes such as severity of use, severity of disorder. They can predict success of treatment or relapse. So in this ketamine purchase task, we asked the participants to imagine that their current protocol is completely covered by health insurance, but they have the option to purchase additional treatments for a copay. And we asked them to indicate how many treatments they will buy in different, across 17 prices, from free to up to $3,000 for a period of time of 90 days. And again, this is beyond their medical treatment that is fully covered. In a second, you'll see those mapped at this graph and the curves, and you'll see how it maps on the other parameters and what's the additional insight it gives us. So these are preliminary results with 198 participants. We're still collecting data, as I said, and mean age 46. The sample is mostly white, educated, and can afford this expensive treatment. The median total number of main treatments is 10.5. 75% of the sample is already 6 treatments and beyond and above. We had about 28% pain patients with or without mental health condition, and about 29% had access to at-home ketamine lozenges. And here are the results. So the liking, people like the dissociation. People like it. These are the mean. The mean is at 23.2. The median is even higher at 31. So 75% of the sample has a score between +10 to +50. People like it. Makes sense that people that can tolerate it are not here, but they're probably also not at any risk for misusing. So people like it, but they don't crave it. The craving is very, very low. These are the means. The medians are all in the zeros. Same for likelihood of use. The bars are the means, very low. The medians are all at the zeros for all 3 products. Same thing for the misuse-related behaviors. This is the mean. The median is in the 0. We had about 15% of the participants that said yes to at least one of the misuse-related behaviors. So overall, we expect these, the demand curves also to be very low, to show very low demand for ketamine. And they do. Let me walk you through this graphs. The x-axis represents the escalating price. This is a logarithm per unit, per infusion or injection. Or people that had at-home access to at-home ketamine, they were asked about the at-home lozenges. So the x-axis is the price, and the y-axis represents the number of the treatments that the participant is choosing to purchase at each price. The blue squares are for infusions, and the orange is for the at-home lozenges. So overall, these are very, very low. These are the median curves, very, very low. We see a little bit higher demand for at-home lozenges. But just as we had a lot of people that said that all the zeros in the other parameters, we had a lot of people, almost 50% of the sample, that said that they will not purchase any. So zero purchase data, will not purchase any additional ketamine. And if we look at these people that said that they will not purchase any, comparing to those that will purchase some, they're less likely, so they significantly like it less, crave it less, and they're less likely to use it in recreational context. So these people are, and this is almost like 50% of the sample, are at very low to no misuse risk. So we wanted to take them out of these curves and look at the curves without those people. And the curves, as expected, go up. And we also see, so these are the median, so 50% are higher data here. So we also see a greater increase for the at-home lozenges. Just looking at correlations, having access to at-home ketamine was correlated with higher craving and both of the items and the misuse-related behaviors. And demand intensity is, where's the, okay, it's the first point there in the first orange point where the ketamine is for free. So this is usually the maximal consumption in addition to their treatments that is covered by insurance. And that number, that intensity there is of at-home ketamine was highly correlated with craving, both items, the likelihood of use in recreational context, the 3 items, and misuse related behaviors. So now we just need to really understand who are these people and try to identify and describe them. We tried to ask why. We don't have. We didn't analyze the qualitative data yet, but these are just some quotes. Why would you want a little more ketamine treatments? We have some of these to experiment with deep meditation, and it's nice to have the option of mental spa day. But we do have more of these. I need more frequent treatment, but can't afford them. Additional treatment would improve my pain management. I like the freedom to get it if I feel I need it. I need more treatments in the winter, and depends on how I feel, sometimes I need an extra treatment. So we see a lot of need, and this is the using substances to cope with poor mental health. This is the kind of use that might develop and evolve to dependence. Summarizing, although ketamine is moderately liked, its misuse potential appears to be low for most patients, but not all. Patients exhibit higher demand for at-home ketamine lozenges than for infusions, injections, which was associated with misuse potential and misuse-related behaviors. More research we need with bigger and diverse samples to identify populations at risk. We're going to look at that. The pain patients, the patients treated at home solely, patients with a history of substance use disorders, and lower socioeconomic status. We need that. Policymakers might consider regulation, standardizing screening, remote monitoring support, and maybe national or maybe international registry. Providers might consider holistic care, making sure that patients have and learn behavioral and cognitive alternatives for coping. Patient education, they need to understand the risk, and provider education, because we sure want to prevent another opioid epidemic, but also to prevent tragedies. Thank you.
much, Shahar. It's time for some question. All right, that is ready with your hands up.
The mic is on the way.
Thank you very much for this very interesting talk. And do you know anything about the monitoring of the patients who were treating ketamine at home? Was there any monitoring? Was there a psychiatrist involved?
So the at-home, like the online one, so online is usually you meet a counselor or some therapist, online for this talk, for an initial assessment or evaluation, and then however many lozenges you buy, they send it to you, and you take it. It's up to you. You have it, so you can take it. Some offer, you can take it with a therapist or with some kind of monitoring, online, again via Zoom, or some people, can take it. That's it. You have them all, and you can do whatever. It's up to you. When you feel ready, you can do that. So it would be really, really interesting to do that survey and these parameters with the at-home. Yeah.
In the Netherlands, we have at-home treatment as well, but with a lot of monitoring. And I'm very curious if your data can be, will be the same in the Netherlands.
So let's talk later. We'll keep on doing it.
A couple of questions. Oh, you have the microphone already. Oh, thanks. Right.
Thank you very much. You mentioned the Fitzgerald paper from 2021, and 29% of recreational users meet the abuse criteria. Mm-hmm. At the risk of sounding slightly controversial, because I know this is a efficacy and safety and addiction conference, but I'm just interested, what constitutes the 71% of non-abusive recreational use? What does that look like? What does that implies that exists, right?
Not every use outside of the therapeutic, or not even misuse, is 100% okay. Misuse and addiction. People can. It's just like with alcohol. Most people drink alcohol without developing an addiction. So, not every use is necessarily 100% an addiction or misuse. Actually, usually a small percentage of people, might be at risk for addiction and misuse. So not every misuse. Usually a small percentage of every substance will develop an addiction and use that is harmful. So the misuse, the addiction, the ketamine use disorder or any substance use disorder is usually identified when it's harming the participants' social relations or work or some functionality at life. So some people use it and they function great. So can you say it's misuse? Can you say it's an addiction?
Thank you.
We have a question over there.
Thank you, Shahar. Thank you, Shahar. That was really nice. You mentioned something, though. You said that people liked it, and they really liked the dissociation. But I wasn't clear whether you were, when you in your survey, were you asking generically if people liked it? In other words, the therapeutic effect, the antidepressant effect, versus the
Good question. Thank you. I should have specified it. Yeah, we separated not the antidepressant effect, but the dissociative effect. We defined that and described that for the participants.
Did you co-factor in antidepressant effects? In other words, were there people who was like, it's not really working as an antidepressant, but I really still like it. I still was.
With this population, most of them. No, we didn't have. We had some people that tried it or went through, the initial series or something, and they said it didn't help us. We stopped. We didn't have any people that said that they're using it for the recreational, and they're not using it for the therapeutic effect. Not in this sample, anyway.
I think. Certainly that's my experience. Is that. If people are not getting a therapeutic effect, they don't want to come back anymore. And in 2020, we published a survey of providers in terms of just because the studies are so limited in terms of numbers, in terms of adverse effects. So we published a survey of at the time I think we got like 40 of the bigger ketamine clinic providers, all about adverse effects. And surprisingly, we asked about addictive-like behaviors, and it was very low. It was surprisingly low. I think there was over 6,000 patients represented in those treatment experience represented in those patients, and it was in low. I mean, 10 to 20 distinct where they had to stop the treatment, and almost in all of them, though, it was they were prescribing it. In addition to like infusions, they were giving home prescriptions for nasal or lozenges, because at the time there was a thinking that we could extend the, when we went through them all, they were almost always the home. In other words, patients were coming back wanting the prescription earlier and so forth. So it was very enlightening. It made me really realize that that's a much higher risky kind of behavior. And I think we're gonna have a debate about that. Actually, it's a good setup.
Yeah, so just, it's a good point. Substance use disorders usually, as a behavioral, this is why, when you look at it with a behavioral lens, it's not just the pharmacology of the substance, but it's the context, or where the person is taking and using or consuming the substance. So it makes sense that it can happen at home rather than in a clinic. Not that I'm saying that the at home is bad.
You know what? When we were talking to all these, we interviewed all the providers who said that they had a patient that had the problem. And I had to, stop prescribing. What happened was they would get a very short antidepressant effect, and in this case, it was driven by the relief from the depression. If they would let's say use nasal compared to the fusion, and then they only supposed to do it twice a day, but then they want it earlier because they had this immediate improvement and it went away after an hour or two, and so that was driving it a lot. So in those cases, I don't think it was about the dissociation. I think it was about the wanting the relief.
Yeah, but this is the use that people use substances for they want to feel better, to cope with the poor mental health. But this this can be the tricky use that can evolve into dependence.
We have a question over there.
Sorry.
And then Robert.
So nonetheless, your query about why are you doing this had a lot. Their responses had the word "need" a lot. Maybe that's a selection bias of the responses you took, but it suggests that in addition to addiction potential, one really should be thinking about these folks as needing perhaps a more comprehensive look and go back with a fresh lens when people start to misuse, rather than just say, oh, that's the percentage of population that's going to do that. So I was struck by the need.
Yeah, and again, this is and it's a multidimensional. You see, like there's the liking and the craving and the need, and it's pretty much when it's a patient, like it's an individual and it's a whole world, and you need to ask the why. You need to see like why the person needs more or wants more, or like the conversation needs to be open, and again, not to depend only on the ketamine, but having a set of other tools to prevent that leaning on the ketamine. Who wanted?
Hi, I'm from Canada. We don't have at-home use at all. I'm just wondering, I knew that they did in the United States. Apparently they do Denmark, you said. I just wonder if you know where else has this. Is this like out? Is this kind of widespread? Yeah, like many other countries. Do they have this?
But Canada has it, at-home use of ketamine. I think we have one last question from Robert.
Thank you for an interesting talk. Preluding a little bit on the debate later today. What we see in the Netherlands is that in some circles, like young people who go to parties, recreational, it might be that all of us, being relatively positive about the antidepressant effects of ketamine, societally seem to lower the barrier to try it without us prescribing it. So we are called by urologists who see severely addicted young people whose bladder is totally knocked out and who cannot stop using, and they have never seen a psychiatrist for depression. Do you have any data for that, on that?
So that's a good point, and it's so complex because it's kind of a cycle. It's not FDA approved, so people can't get access to it. Only those that can afford this right now in the U.S. And so they might go into that recreational use or less monitored use. So. Yeah, this is why
If I look at the American movies, I presume there's drug dealers in the U.S.
No. Only in the U.S., not anywhere else. Yeah, so it's a problem, and it happens. So this is also, we see also with the cannabis, the cannabis is overly perceived as safe and therapeutical, and it is becoming, an evolving public health concern, just the cannabis, because everybody uses it and not aware, not educated enough to understand that it can evolve to a harmful use. And so we need to learn the lessons from one substance to the other.
It's interesting, though, that even though ketamine is probably the most popular as used as a treatment in the States, its abuse is much lower than places where they don't use it. So that kind of argues against that. We're facilitating that. I mean, I think in Great Britain, has a higher ketamine problem. Certainly China does, and you can't have ketamine clinics there. So I think it's very much cultural as well. What drugs are people attracted to? It's very cultural.
Yeah, popular.
It is growing in the U.S.
Yes, it is growing.
It's growing.
It is growing, and it's we need to be a step ahead and not wait for the problem to explode. And there's a lot of work to do yet.
Well, thank you very much, Shahar.
Thank you.
So this